Good afternoon, everybody. I welcome you all post-lunch session. We will start with our first session, that is Grunting Child. I request the panelists to kindly come. Dr. A.K. Basu, Dr. Pramod Chaudhary, Dr. Shalini Agarwal, to kindly come and come to the stage. Now I call upon the moderator, Dr. Arun Manglik, sir.
Thank you very much. And at the outset, I'll express my sincere thanks to the organizers for having me here. The topic allotted was grunting child. And at the outset only, I had asked the organizers to expand it a little bit, because the grunting child means it's a very narrow spectrum. Means you're talking basically of pneumonias and nothing beyond that. So we decided that we'll have the discussion on noisy breathing in children. Though this is a sparse audience, but many of you might be having people who are in general practice or in pediatric practice who happen to see children, do happen to see parents really worried. मेरा बच्चा तो घों घों करता रहता है, আমার বাচ্চা সব সময় একটা আওয়াজ হয় বুক থেকে, and then you find out that most of the time it is nothing serious and you have to reassure them. So we'll discuss these issues in the next maybe 3/4 of an hour. It's not moving. आगे move नहीं हो रहा, अब आ गया. Thank you. So noisy breathing is a very common cause for concern for the parents. It's our job to realize and to find out how bad or serious the situation is. 9 times out of 10, it may not be serious, but one time when it is serious, it may be really bad. So this noise can originate from anywhere of these places, the entire airway, starting from the nose to almost the alveoli, but alveoli don't produce sounds. It's the bronchioles or the bronchi. Alveoli also have, and we'll come to that in the next few slides. Imagine the chest wall deformities can also produce sounds. So what are the respiratory sounds? This we know from our undergraduate days, the vesicular and the bronchial ones, and this is very well known to all of us. The abnormal sounds, this is what we are interested in. Wheeze, particularly in asthma, bronchiolitis, we can have this as a high-pitched musical sound, which is continuous, mostly expiratory, but sometimes it can be biphasic also. It could be rales, which are fine or coarse. When they are fine, they are soft and high-pitched. They occur in pulmonary edema and early pneumonias. Whereas when the pneumonia is advanced, we have coarse sounds. We have these further, stridor, which originates from the upper airway. Any upper airway obstruction leads to a stridor, and we'll let you hear the sounds as they come up in the subsequent slides, because we've got some videos for you. The grunt is something which we all are very wary about. We abhor the grunt, because the grunt means what? The child is trying to exhale against a closed glossus. Okay? And the child does this, something like this. This sound itself tells us there's something serious going on. And whenever this sound comes up, we always take it with a very big, say, a kilo of salt, not a pinch of salt. Snoring sounds are very common. Particularly, they occur because of a partially blocked nose, and that could be taken care of by adequate use of nasal sprays. Snuffles. Well, snuffles we learned in our undergraduate days about congenital syphilis. Yes, that has gone down dramatically over the last decades, but we still have snuffles or a sound caused by nasal congestion, and particularly in the newborn, it could be evident. Now, the causes could be this galore, and I need not read out all this because this is available in any textbook. It could originate from the pharynx or larynx. The causes could be congenital or acquired, like laryngomalacia, which is congenital, or subglottic stenosis. Croup or epiglottis could be infections. A last tonsil is actually mechanically obstructing. It is a high, stridor is a high-pitched sound. Trachea, it could be again a congenital defect. Malacia, that is, what does malacia mean? That is, the airway is soft. Though the airway the conducting airways have got cartilages. The cartilages are incomplete, as we all know, and they are softish. They tend to fluff. It's like a bird's wings, purr, 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 something like that. And if it is if there's a foreign body in the trachea, or there's external compression by a lymph node, or by a left-sided aortic arch, which could compress upon that, all these things can cause, and again that would be stridor if it is again above the glottis. Below the vocal cord and lower airways, we can have causes could be asthma, bronchiolitis, pneumonia, and all that, and it could be wheeze or crackles. Chest muscles. If the chest wall has got weak muscles, we get what is labored breathing. And any pediatrician who has seen this can realize this very easily. The child breathes with difficulty. You can make out that the child is having real difficulty when the child is trying to breathe. Now, we come to some patients now. Now, this is a 5-year-old who has this sound, and I'll let you hear the sound before you can read it on the right side. And what is actually the child doing?
আওয়াজটা বন্ধ করতে বাইরে আওয়াজটা বন্ধ করতে
So, anybody could suggest what could be this sound? Sir, and now, what would be your opinion, Dr. Shalini, on this? Would you do any investigation, or the clinicals tells you what could be the possible diagnosis?
Hello. Yeah. So, sir, this is classically telling it's a 5-month.
Working?
No, it's not. It's not working. Hello. Yeah, it's working. Huh? Hello. Yeah. So it's written like it's a 5-month-old child. So good thing is the baby is growing well. So we are. Yeah. So this is a very important point from the pediatrics when we say. But the sound got worsened with a 3-day episode of fever is there at 3 months of age. So this is like basically a sound which is coming and looking like an inspiratory.
Absolutely.
Because it's a suprasternal retraction cleaner, you know, we can see easily. And with which is noise, so it's looking like a stridor. I'll take that as a, you know, first in my patient. For this case, the baby was well immunized at the government center, so they really take care of all the vaccination. So I am like not worrying about, you know, something with H influenza and all those things.
Particularly in view of the history that the child has had this sound since 1 month of age.
Yes, sir.
So it's something which is there from very early age.
Yes, sir.
So more likely to be a congenital problem.
Yes, sir.
Okay, unlikely that the child will have an infectious origin for this
Exactly,
patient.
sir. Exactly, sir.
Okay, so any investigation, I mean, this sort of an history would be almost a clinical diagnosis.
Right, sir.
So what do you think is the diagnosis?
So it's looking like laryngomalacia.
Yeah. So the larynx is actually very flab. The cartilage over there is so damn soft that when the child breathes in and breathes out, when the child breathes in, it flutters like the bird's wings. And this causes that sound. And obviously the parents are very worried. And they've had this sound from the 1 month of age, and now the child is 4 months after that, 5 months of age. The good part is the child is thriving well. And any investigation would you like to do? Sir? Any investigation?
Basically, laryngomalacia is a clinical diagnosis, and with time it improves gradually.
Put it closer to your.
Hello.
Yeah.
Basically, laryngomalacia is a clinical diagnosis, and usually no investigation is required. But if it doesn't improve with the time, we may do bronchoscopy, in which we will see the muscles of our larynx are coming closer.
So we do a scopy to look at the larynx, and when we do this, when you try to introduce a scope itself, the scopist tells us very clearly that this is a fragile, very fragile larynx and the walls are collapsing. Okay, so and the likely outcome, he has already outlined that 9 times out of 10, these patients recover. The sound disappears when the child is around maybe a year and a half old. But this is 9 times out of 10. And this is what it looks like This photo is courtesy Dr. Basu itself. And you can see on the left side the normal one, and on the right side we have this. Sir, would you like to describe this?
Thank you, Dr. Manglik, for inviting me in this panel discussion of the physicians and the surgeons are the odd one out. And I'm very worried in the panel discussion. I thought I'll be given some questions earlier and I'll prepare for them. So I had made my own presentation for a child who is having a stridor. Stridor means a child is breathing against a closed glottis or an airway obstruction. Two things, closed glottis or there is an obstruction in the airway. I have many more pictures where you can have a stridor like this, but this particular child who is an infant of good body weight, otherwise no problem, but having a stridor. Most likely this is a patient of laryngotracheomalacia. We call them laryngotracheomalacia because the airway is also defected at the same time as the larynx. And the laryngotracheomalacia can be diagnosed very easily is that if we just pass in an endotracheal tube through the larynx, the noise goes. Similarly, if we do an endoscopy, it looks like this. Initially, when the child is breathing out, the laryngeal opening is open. The moment he starts breathing in on the right side, if there is a pointer, it would be very nice.
I'm pointing it out for you,
Yeah,
sir.
that's right. Thank you very much. The whole of the arytenoid and the glottis falls down onto the laryngeal inlet and the larynx almost closes. But the closure is not as severe as to give rise to fall in oxygen saturation or
So
interference
we'll come to
with
that,
the feeding.
sir. So we'll come to that. We have another patient who's not gaining weight, similar history. He's not gaining weight, child is getting cyanosed, saturations are falling. So anything we would do, both from the medical side and from the surgical side. Anything we would do from the medical side. Now this child is not thriving well, so we need to take care of that also. So what would we do for the feeding part? And from the surgical side, we'd request sir to tell us that what would you do for as surgery is concerned. So Shalini, from the medical side, how could we help the child?
Yeah. So, sir, now we have two concerns for this baby. One is the child is not gaining weight. Another, the baby is not maintaining the saturation. So, again, sir, since when the child was not maintaining the saturation?
So suppose this child is now 5 months old, child was born 2.45 kilos, now the child is 3.5. So child is not at all gaining weight, very
Not
poor.
gaining weight, yeah.
Okay, and saturations, whenever the child tries to feed, saturations fall. I mean, they find out that the child gets blue. When they take the child to the hospital, when they find that they are trying to feed the child orally, the saturations have fallen down to 70s to 80s and like that.
So, in that case, sir, we need to obviously admit the child,
Yeah.
put the baby oxygen via nasal prongs, I think will be fine.
Perfect.
And we can start initially with a tube feeding.
Absolutely,
Yeah.
that's the thing we need to do. Child cannot take orally, so we got to bypass the structure which is obstructing, because whenever we try to feed, the things collapse severely and the child desaturates. Exactly, that's what we, and if the parents want a surgical opinion and anything from the surgery point of view, would you help, sir?
See, for giving the proper treatment, we must have some differential diagnosis in mind. And the differential diagnosis in a patient who, as you described, that desaturates while feeding and has respiratory distress.
So the child has got a bronchoscopy done. The bronchoscopy has confirmed this is laryngomalacia extending into the larynx only. And then anything we can do about it?
Another two things which come to my mind initially is, one is a P.I. syndrome, where there is a hypognathia, small tongue, and it falls and closes the laryngeal inlet just like this.
So the child doesn't have a period
It doesn't have a
parameter.
period. Then we have a H-type fistula where the child also do not thrive, and while you are trying to feed, the child aspirates through the fistula into the lungs.
No, sir,
and also have similar
the cords
problems.
are collapsing. The larynx is collapsing. So the diagnosis is clear. So anything from the surgical side, can we do anything?
Yes. So one thing we usually try and not do is a tracheostomy. So we try and avoid tracheostomy. We may put in an endotracheal tube if there is a serious problem, but a patient of isolated laryngeal malacia usually do not need more support than putting the patient prone or lateral and feed through a nasogastric tube.
Absolutely.
That's what will take care of the problem.
Absolutely. I wholly agree with sir that most of the time, despite the child not gaining weight, probably the child was not well managed. And if you start tube feeding and the child is fed well, the child will gain weight and probably will grow out of this friable cartilage that the child has been born with. So we come to another patient. We have another similar patient, and you can hear the sounds.
pay பண்ண போகுமா
Now, this is another patient who had presented with a similar fashion, but the endoscopy done showed up subglottic stenosis. Now, this is a far more difficult issue than the laryngomalacia. We need the surgeon's help in a big way now.
That's the whole problem. The physician first gets the patient and they do all sorts of examination, all sorts of investigation, and when they are exhausted with everything, they
No, sir, the
most
patient still has money.
reluctantly will turn
Paisa hai.
to the surgeon and say, please find out what has happened. And the surgeon puts in his endoscope, and this is one of my pictures where I find definitely there is a subglottic stenosis. Now, subglottic stenosis are a rather difficult problem to be solved at this age. If the child is a little older, then we can have ways to treat the subglottic stenosis, like endoscopic division of the valve. This is a complete circle. Sometimes there are waves at the back, and you can do endoscopic slicing of the valve, and the opening gets bigger, the child gets better. But at this moment, we'll have to feed the child through nasogastric tube and try and do some sort of a dilatation of the airway. And there are desperate times when we may need to do a temporary tracheostomy and do a surgery, endoscopic or external, to get rid of the subglottic problem. This is a subglottic membrane. And after we have done that quickly, we'll take out the tracheostomy tube at the earliest, because tracheostomy in a newborn often give rise to subsequent problem of granulation tissue and stenosis. So we want to avoid it, but in such a patient, we may need a temporary tracheostomy.
Thank you, sir. And this is sir's patient itself. And these are further sir's photographs which he has sent to us. And you can have these sort of issues, huge tongue or a big cystic hygroma, which is obstructing. Basically, these are mechanical obstructions which is obstructing the upper airway, and the stridor is, the sound is coming up. These need to be treated accordingly. Now we have another patient.
One second, one second. Not only cystic hygroma, there may be any sort of tumor in the neck or in the pharynx and can obstruct the airway to give rise to a stridor. So stridor and a tumor in the neck for certain duration of time also leads to secondary malacia of the airway. So even if you take out the tumor, the airway may still remain pliable and the patient may continue to have a stridor. So while treating a patient with neck swelling, we must make sure that we handle it properly so that even after surgery, there are no problems.
So we come to our next patient. This child is 7 months, has not grown very well, quite rather less well grown, and fever for 2 days quite high. Child has got cough, child is very irritable, and this is what we have. There's less of urine, the child has received inadequately immunized. Just 1 dose of hexavalent vaccine at the government sector, and the child is desaturating. So this is the situation of the child when the child has come and the oxygen is being arranged. So once the oxygen has been arranged and the child is also being nebulized, so what next? What next, Shalini? This was the X-ray.
Huh. So, sir, this is like the history itself is telling that the baby is not gaining weight, okay, with a history of fever. And the most important history which we are having is that the child was not immunized. So, this itself gives us a very important clue that can be an infection.
Absolutely. And did you hear the sound? There was
Yes,
a
sir.
typical grunt over there.
Yeah.
So this was the
This was-
X-ray,
yeah.
child admitted. Now we need to know what antibiotics would we give.
So, this is looking like a community acquired pneumonia.
Absolutely.
Yeah. So,
Which antibiotics would we give?
sir, sir, I think, sir, we can always start with an amoxicillin clavulanic acid combination, sir. I think, yeah, that's a very good combination to start with, at least in the pediatric range.
We have this age-related criteria mentioned by the Indian Academy of Pediatrics. Yeah, you can discuss.
Yeah, sure, sir. Sure. So basically, sir, please, you discuss.
In case of community, hello. Hi. In case of community acquired pneumonia, up to 3 months of age, every pneumonia will be treated like a severe pneumonia and will be admitted and started IV antibiotics. And that is, we can start with amoxicillin clavulanic acid or third generation cephalosporin like cefuroxime. From 3 months to 5 years of age, the first line of treatment will be amoxicillin. The second line treatment will consist of co-amoxicillin and or chloramphenicol. And in suspected staphylococcal disease, we can give cefuroxime or co-amoxicillin acid or amoxicillin or cloxacillin. From 5 years onward, the first line of therapy will be amoxicillin, and second line therapy will include macrolide or co-amoxicillin or chloramphenicol. And in suspected staphylococcal disease, we can add cefuroxime or co-amoxicillin clavulanic acid or amoxicillin or cloxacillin.
Thank you, Dr. Chaudhary. So the antibiotic guidelines are quite clear. The basic idea of having these guidelines is to have adequate antibiotic stewardship. We don't want unnecessary excessive overuse of antibiotics. So that is the reason why you might be wondering that any child above the age of 3 months, and if the child is really not bad, then you can start on an OPD basis, co-amoxiclav, and things work very well in most cases. Now this is another child who is known asthmatic, who is on inhalers, but the child has been irregular in taking the inhalers. The child had stopped the inhalers for the last 4 months. And for the last 2 months, some renovation was going on, so obviously the triggering factors were there. Came in a severe attack, and the child was speaking in single words. Ami na ajke kichu khai nahi. Something like that. So you can hear. This is actually in a ward, so you have other sounds. So how would we manage?
From history and picture, hello. From
This is
history
an
and,
acute severe attack.
hello, this is a very severe acute attack of the asthma. And first we will have to treat this patient as an inpatient and with a proper hydration, and we will start oxygen therapy, and then we will give short-acting bronchodilator therapy or nebulizer every 20 minutes for 3 such shots. Along with this, we will add the ipratropium steroid, and in last we can give, I also give the IV magnesium sulfate injection.
Absolutely. So this is very almost standardized. We have 3 puffs of Some people would say nebulization would be better off than using simple MDIs and a spacer. Well, both of them work equally well. And if you are in a hospital, most people usually use nebulizers. But if you are in a domestic setting, simple use of short-acting beta agonists, as you mentioned, albuterol, can be given. And at the same time, now we have coming up with the MART therapy, where we have the albuterol or the salmeterol along with salbutamol, we give along with steroids. And there we have this for something like formoterol as well as the other budesonide combination we are using. So this is the GINA guideline, which is as late as May 2025, where it is clear that you give 4 puffs of short-acting beta agonists, 3 such at 20 minutes gap. Quite often we don't even wait for 20 minutes, we go in faster. The only issue is sometimes they can produce some bit of tremor. At hospital, you must give oxygen, and whenever you are using nebulizations, please nebulize with oxygen. Never nebulize with the machine directly, always use with oxygen. At least you must have a separate port introduced into the nebulization chamber. Why? Because nebulization would produce a VQ mismatch, and because of the VQ mismatch, the places where it is being aerated, you will not get a blood flow. So we need to give oxygen, because it has been found that if you do not give oxygen, it results in saturations falling down. We don't want that. And the last GINA guideline says, don't use nebulized Maxulf. You can give IV Maxulf quite safely. We have another patient now. 2-year-old, breathing difficulty, and this is what the patient looks like. So this is another history which was revealed when a detailed history was taken. Child was playing outside with a lot of things, marbles, coins and other things, toys and all that, and a 7-year-old sister was also there. Child was also tending to put some of these articles into the mouth. And obviously, there was a suspicion. And so now we have again our surgeon, sir, to help us. These are again his x-rays. These are not the x-rays of this patient. These are his x-rays which he's provided to me.
See, it's always easy to suspect foreign body in the airway in a child, because the child will never say that I have put something inside. And it is usually the bystanders, like the friends or the mother, will say the child had put something in the mouth, and the trouble started after that. And in most of the patients of foreign body in the airway, there is respiratory distress and cough. But an important finding in a patient with foreign body in the airway is reduced airway on the side of the blockage. That means if the right bronchus is blocked, right side will have less air entry and vice versa. But if there is a foreign body in the trachea, that child will have severe respiratory distress and cough. Severe. But if you listen to lung on 2 sides, the air entry will be equal.
Yes.
And it becomes a difficult diagnostic problem. I have just selected these 2 X-rays. I have many more such X-rays. They are opaque foreign bodies, and I have selected them just to make it amply clear that they are tracheal foreign bodies. And these foreign bodies will have severe respiratory distress, as he just made us to hear. And they may look dangerous, but it's not at all difficult to put in an endoscope and then put in a foreign body holding forces and take out these foreign bodies. And the results are dramatic improvement. I had also another picture of a safety pin. Is there
It's there.
There is a safety
On the
pin.
left one.
Yeah. I was lucky to get hold of the back of the safety pin and take it out. But if the safety pin is twisted the other way, we'll have to close the safety pin inside the airway and then take it out. That becomes a difficult problem. Otherwise, treating such patients are easy. Diagnosing such patient through an X-ray is
The
easy.
problem arises something different, sir. Suppose the foreign body is not radiopaque. You have a food material, maybe say a peanut,
See, that's what I
small
said.
child. There it becomes a real mess because the child has come with distress, child has come with cough, with what the video we showed.
Yeah.
And then, but on the X-ray we will have some telltale features which
Yes.
which you can make out that this is possibly a foreign body.
Yes.
And then obviously the
Yeah.
bronchoscopist or your help will be useful. Yeah, would you like to describe any more?
Yeah, there are some rules of thumbs. One is there any history of choking? That means mother will say the child was having moody or badam, and suddenly the child had a bout of cough, and then everything settled down. But since then the child is unwell, having cough and cold, and the child is unable to feed properly. In such a child, when you see, the child will have intercostal or substernal suction, and if you listen to the air entry will be definitely reduced on the side the air body is lost. Even if we do a number of imaging like ultrasound or a CT scan or an MR scan, that foreign body will not be visible unless the foreign bodies are like this, radio opaque. So in such a scenario, if one of the pediatricians who is a outstanding pediatrician of the city has said there is a foreign body, the poor surgeon has no other choice but to put in an endoscope and make sure there is no foreign body. And if he finds a foreign body, to take it out. And the results of taking out foreign body are really, really dramatic and remarkable.
So the problem arises even further down. Suppose you have a vegetable foreign body and X-rays were done and some other diagnosis were given. Child was giving short-acting beta agonists considering bronchiolitis or an asthma. And this passes on for a few weeks or few months. And then the child comes up with a pneumonia because the child has developed an infection at the site where the foreign body is still lodged. Now, the foreign body may have gone deeper down depending on how big the caliber of the foreign body was and how much it can go into which bronchi, depending on the caliber. Now, once that happens, what mostly we do as physicians, we treat the pneumonia. We forget that the child may be having an underlying trigger which is causing the pneumonia over there. The concept comes again when the child comes back again 6 weeks later or 3 months later with again a pneumonia on the same side. Then our antenna gets up and then we say, kuch to hai, which we are missing. And then we go and then he is in a real mess because the situation is, it is a foreign body which is probably vegetable, which has actually eroded the airway, which has got a bit of fibrosis around it, and it becomes real tough for them. So it's imperative on us to make sure that we don't miss out foreign bodies as early as possible. Am I right, sir?
Yes, vegetable foreign bodies have two difficulties if they are old foreign bodies. One, as he said, a peanut or any nut of that matter swells up and becomes soft, and it gets stuck in the airway. So even if you can hold it, the moment you hold it, it will break. So many times I had occasions where I had to irrigate and take out the foreign body piecemeal. The other problem with a vegetable foreign body is that if it is a seed, like babul bichi is dangerous. They swell up and almost become double the size, and they are still hard nuts. And even if you can hold it with your foreign body forceps, when you come at the glottis, it will slip out again. And it may go to the other side. So you may need to crush that foreign body with a non-optical foreign body forceps, which are very strong, and then take it out. So yes, foreign bodies, even if they are vegetable foreign bodies, may definitely put us in trouble many a times.
So we have another patient now. This is a 6-month-old child who's come with fever for a few days with not very high fever, noisy breathing, not feeding well, and this is what we get. So this is the, and the trigger, the big indicator here is the child has a very bad barking cough, which, and the child has been vaccinated in private. Child has got full vaccinations of 3 doses of hexavalent vaccine as of now. So likelihood of the child developing Hib infection leading to epiglottitis is very less. So what do you think it has happened?
Sir, this is a classical history. It's giving like a 6-month. The age is very specific with a temperature, with a noisy breathing, and the cough. The cough is very, very essential in this case. It's like a bad barking cough. Exactly, the sound is coming the very same, and the saturations are low. Just by oxygenation, only the saturations are coming up. So it's looking like it can be a croup, like a laryngotracheobronchitis.
Absolutely. And so what happened after, see what happens after 1 dose of epinephrine.
So I think that's
Child is fairly quiet now. So
the
this
beauty,
is it.
sir. I felt like with the age, with the sound, we can manage. Not with so much of investigations we need in pediatrics. It's more of clinical, and we actually, the babies, they respond very well.
Quite often we don't have the time to do the
I
investigation.
agree, sir.
And so we have another child like this, you can hear, and this child is not that severe. Look at the child's eyes. Child is really worried for his life. Anxious. So, how do we grade?
Hello. We can grade group in mild, moderate, and severe variety. We will look for few features, that is general appearance, stridor, respiratory distress, and oxygenation. If child is happy, feeding well, and interested in surrounding, then it is mild cough, mild croup. In this case, a stridor will be present on coughing and crying, but not at rest. And there will be no respiratory distress, and the child will be maintaining SpO2 greater than 92% in room air. In case of moderate croup, the child will be fussy but interactive and comforted by the parents, and there will be stridor at rest, worsening with agitation, and there will be respiratory distress in form of tachypnea, tachycardia, and chest retraction, but oxygen saturation will be maintained above 92% in room air. In case of severe croup, the child will be restless, agitated, and with altered sensorium, and stridor will be present at rest, worsening with agitation and crying, and there will be respiratory distress with marked tachycardia and tachypnea and with chest retraction, and the SpO2 will be less than 92% room air, and there will be cyanosis also.
Thank you. And so, how do we treat?
In mild croup, usually nothing is required, and since child is maintaining SpO2 more than 92% room air, so there is no need of oxygen and there is no need of antibiotics. But in case of moderate croup, the child will require oral steroid or nebulization with adrenaline, but there will be no role of oxygen and antibiotics. In case of severe croup, along with the steroid and nebulization, we may need nebulized adrenaline, and we will have to repeat the dose. And if the child is not maintaining oxygen saturation above 92%, we will have to give oxygen, and there will be no role of antibiotics.
Thank you, sir. So, basically it's a viral infection, so antibiotics are out. Oxygen as per requirement. The two mainstays are epinephrine and steroids. The problem with epinephrine is it acts fast, but the duration of action is only 2 hours. So you may need to give repeated doses, and there's a possibility of rebound worsening of the condition if we don't repeat the dose. At the same time, one entity which we nowadays don't see much is epiglottitis. These presentations would be very similar, like croup, but in epiglottitis, the fever would be much higher, of shorter duration, maybe ranging to 103, 104, and the child is likely to be unimmunized because it is mostly due to Hib infection. Following the Hib vaccine coming up in a big way for the last 20 years, this entity has gone. The main problem with epiglottitis is, if I try to examine the child, I am going to kill the child. It's as bad as that. So I just would not try to examine. If I suspect epiglottitis, I take care of the airway fast, maybe even putting an ET tube. But if I try to examine, because it will collapse and the airway may be totally blocked. So as I said, I may be responsible for something disastrous.
Sorry, one
Yes, sir.
thing. In ICH, we get a lot of patients who come from a poor economic strata, and we have a very good ENT surgeon, and we have had occasions of seeing even epiglottic abscess. It progresses to abscess, and once you drain it and treat the infection, the patient gets better.
Sir, right, absolutely. And we have another entity like a retropharyngeal abscess also.
That's right.
And those also can present with stridor, and they are really very difficult to diagnose. You have to look at the posterior pharyngeal wall, and then you can see a bulge over there, and probably that will tell you that this is an abscess developing over there. So we have another patient. This is a 2-month-old who has peculiar signs when child is sleeping. Parents are really worried. They have not been breastfeeding, only bottle feeding, and the child is thriving well. So what do we, just try to hear. Sound will come. Could you hear something? Following the sound, the child is moving around the head. So that's exactly what you saw. After the sound, the infant struggles and wakes up, and then tends to may rub the nose, or may shake the head a little bit, or this way or that way, and falls back to sleep. What's happening?
So, like, this is one of the most common thing which we come as an OPD practice when it comes to. So, it's a 2-month-old child, thriving well, feeding well, but the problem is the nasal blockage.
Exactly.
So, this is one of the most common thing which parents come to us because the temperature is not well maintained, like in the environment. So that causes the nostrils, which are
What would we do about the nasal block?
So we just give saline drops.
Absolutely.
Yeah.
I mean, giving anything beyond saline like oxymetazoline or xylometazoline is definitely going to
Not
do more harm than
recommended.
good.
Yeah, I agree.
Maybe you may use it once in a while, maybe once in a week or something at the bedtime when the child is off to sleep. Otherwise, most of the time, a nasal spray. And the best part is now we have plenty of normal saline sprays. You use the spray, instead of using it as a drop, push it a little bit inside the nose and use it as a spray. Then what actually...
It works very well.
Then that works very well. In fact, we have some preparations which come directly in the form of sprays. They have those nozzles coming up and you just push it over there, and the wonder it does is it clears off the nose. There may be the child's nasal aperture is this small, and a little bit of debris over there will cause obstruction, and the child will have difficulty in breathing. So once you put the spray over there, it tends to dislodge everything. And all that material over there is probably pushed back into the pharynx, and the child may overtake it, may gulp it down into the tummy, that's all. But at least the child can breathe well. Okay? So this is something very common, and what we need to do is to reassure them and just give nasal spray, as it's very rightly pointed out. Now this is Shalini's patient. So I'd ask her to detail us about this. Yeah, go ahead.
So shall I stand?
Yeah, you can start, you can do.
So just that this is a patient, was outborn baby, came to us like in our hospital after day 2 of life, okay. So, but baby developed respiratory distress at 2 hours of life. Outborn baby, as you know, from the peripheral center, baby was received oxygen. The parents didn't give us a history of bag and mask ventilation, but definitely baby was given bag and mask ventilation outside. So at 38 hours of life, when we received in our center, we saw the baby has developed severe respiratory distress. So the Downey score was 8 by 10. So with a decreased air entry bilaterally and SpO2 of 84 percentage, and baby came in oxygen via nasal prongs. Baby was not even intubated during the referral. It was like only in prongs they shifted to the baby. So the thing which they have missed maybe in the periphery was the mother had a history of UTI at 5 months and 8 months of age. So at the moment we came, we did one X-ray. So this X-ray, came the concern. In the 5 a.m. in the morning, we all rushed to the hospital. So baby developed severe tension pneumothorax on the left side with a pneumothorax on the right side also. So immediately drain was put. The second X-ray, sir. So one thing which I want to highlight, the two sounds which were very important, like for us in this case was, baby had grunting with a decreased air entry. We didn't had at that time this torch to see that. The cold light was not available with us. We did the X-ray. Through that only we diagnosed that it's a tension pneumothorax on the left side and the bilateral pneumothorax. We put the drain, we can see that the collapsed lung opened up on the left side. The right side still, we were very confused with the right side. Whether the right side, sir? Yeah, the drain was placed on the left side, but the right side was causing us more confusion. Whether the pneumothorax is still persisting or not. We discussed with radiologist, everyone was like, we have to go for a CT scan. So the next X-ray but gave us a better picture. So the next X-ray told us no, the pneumothorax persisted on the left side, but the right side is more of a necrotizing pneumonia. But the right side, that tension pneumothorax was not there. So that time we even discussed with a surgeon, like a pediatric surgeon was invited. Even we discussed with him. He was like, since the baby was intubated, was maintaining the saturations, to keep it to this state only, there was no need of a chest tube drainage was not required as per his opinion. But then we saw that with the course of an antibiotic, that the baby responded so well that our both bilateral were clears. So there were a lot of differentials which came into our mind. So this two other scoring system. So as this is a presentation on the sounds, so we could realize that sounds are so important. So two main scoring systems which we are using in units, they are based mostly on sounds. The two important sounds we score which we use, one is the Silverman-Anderson score, another is the Downey score. So the both gradings are there. Like I think we don't need to discuss in detail, sir. This is like not there. So the differentials, when we just with these two sounds and we know X-ray, there were a lot of things came into our mind. First, whether can it be a hyaline membrane disease? But again, points against was, baby was not a preterm. There was no history. We didn't have a history of any antenatal corticosteroid. Again, the X-ray showed no air bronchogram. But something which was pointing, because the second X-ray was showing little bit of, that hyaline membrane disease, and our culture showed no growth of organism. Although the background history was there, but there was nothing. Second came, can it be a TTNB? Like that over phone when we heard, a term baby at 48 hours of life distress happening, can be a TTND. But again, we did an X-ray, we did ultrasound, there was no prominent fissures. Although the history is really going towards transient tachypnea. 2 hours of life baby was going. So this is where we fit in. A congenital pneumonia with pneumothorax. Because the mother had a positive history of UTI, cold light came out positive. So X-ray has classical infiltration with like lot of necrotizing pneumonia like picture, but something which is going always against our bulb fluid. The biofire test was also showing no growth of organism. So everything was no growth. Again, even we have a pulmonologist, sir was also there along with us. So CPAM type 2 he said. But again CT thorax we did, that showed no signs of CPAM. So finally, it can be a lung hypoplasia also. Yeah. So, but again, because there was no further features of adding to lung hypoplasia, we excluded lung hypoplasia also. So we stick to our diagnosis of congenital pneumonia with pneumothorax. We treated with a atypical coverage of antibiotic. I think that clicked it, because the most common organism from the mother to the baby, like in early onset sepsis, which happens is group B streptococcus. So considering that only, sir, we added meropenem, vancomycin, even atypical clindamycin was added. With that, the baby showed dramatic response. The baby responded, stayed with us for 10 days, gained weight, then baby was extubated. I think in the entire scenario, the POCUS really helped us. It was like wonderful. Like we could see the very day the baby was admitted, we did the POCUS, we saw it's necrotizing in pneumonia.
POCUS means point of care ultrasound, that's all.
So we chest tube, are all reports. Something which was always going against our diagnosis was all the cultures were negative. Only we got a high procal to 18 was our procal. That went into declining trend, and the baby was extubated, then feeding was established, and everything was taken care of.
Thank you. So you've done a wonderful job, and I intentionally highlighted POCUS in red because that is something which is very much now in practice and we must do it. Ultrasonography of the chest is something very much in practice and we can get a lot of information, and in the next case we'll just highlight that again. We have a 2-year-old boy who comes with cough for 7 days, fever for 2 days. Child came to our institute, which is not a tertiary care, level 3 care center. Distress for 24 hours, child was lethargic, saturations were low, were okay in room air, 94%. Tachypnic, detractions were there, bilateral bronchi and Krebs. So this was the X-ray. Again, looks like a simple community-acquired pneumonia. Things should settle down. But it didn't go as we planned. Child was admitted in our center and child got coamoxiclav, child not improving, so shifted over to Mero and Vanco. Started deteriorating on day 3 of admission. That is day 5 of illness. The counts were not very significant. The CRP was not very bad. 39 is not very bad. So we shifted baby to ICH on day 5 because the child was quite bad, and by the time we could shift, child was almost gasping. Child was hypotensive, hypoxic, and had mixed acidosis once we got the ABGs done. And this was the picture at that point of time at admission at ICH. So what we had done, we had not done a great job at all. We had practically failed in getting the child out of the woods. So this was the X-ray, and this obviously had something very, very sinister. Child was intubated over there, put on mechanical ventilation, inotropes, boluses were given, sedated with morphine and midazolam, ceftriaxone, Vanco was started. Okay, imagine we had started Mero and Vanco, maybe for only 24 hours. They shifted over to ceftriaxone, Vanco. That is basically a bit of a step down. So next possible investigation, why I have highlighted that, was POCUS. Once we got the ultrasound done over there, it showed us a right-sided massive effusion, collapse, consolidation, but septations were minimal. Now this could guide us our therapy. If the septations are not there, that means you can just put in a drain and be happy about it. But if there are plenty of septations, probably you'll have to put in streptokinase or urokinase to dissolve the septations, or you may even have to do a thoracotomy. And then probably sir will come up. ICT was given, hemorrhagic hazy fluid came out. Again, the CRP was similar, and things were not all that bad. Now, nowadays we can do BAL, that is bronchoalveolar lavage. Everything came out negative. The pleural fluid, CB-NAT, that is for tuberculosis, that also came out negative. The high fever was still persisting. The CRP was coming down. So the BAL gave us this. When we did the PCR for BAL, adenovirus, which was almost in an epidemic form last year. So we had a lot of adenoviruses coming up, and in most adenoviruses we do get some infections, some cough, some cold, a bit of fever, but they did not progress to this stage. As we say, most influenzas are mild, but some influenzas, particularly for elderlies, people with diabetes and other comorbidities, can end up with pneumonia, and they can kill also. That's the reason why we have this influenza vaccine for adults every year. Fever subsided, child was extubated, discharged. So finally, noisy breathing is a common complaint. Mostly the problem may not be severe, but we must keep our antenna high, our We must be sure that we are not dealing with a serious problem. We must have a high level of suspicion, recognize serious issues fast. Sometimes they could be life-threatening. The sounds tell us the site of obstruction. Upper airway obstructions we are more worried about them because they can be life-threatening, they can obstruct the airway, and the child can develop into serious problems. So finally, we'll end up with this quote from Dr. APJ Abdul Kalam. सपने क्या होते हैं? जो हम रात को देखते हैं वो सपने नहीं होते हैं, जो हमको रात को सोने नहीं देते हैं वो सपने होते हैं. That was Dr. Abdul J. Kalam. So thank you all.
Can I make a comment on this particular patient?
Kunta?
The last one.
और आगे?
The last patient, you said the right side completely white.
हाँ हाँ हाँ.
It may be prudent to just put in a needle, take out some of the fluid, and examine it. And depending on the results of that examination, we can go ahead and do further treatment. Because we have done the ultrasound, it showed there is effusion, it showed there is septator, it showed there is collapse. So just put in a needle and examine the...
Agreed.
That is a usual approach at ICH. I don't know how this patient did not have that.
So thank you, sir.
We have missed a very big part of Grunting Child are the neonates. I had many x-rays of the neonates. I'm sorry, because of shortage of time, we are not seeing them. But we did not include the newborns.
Can we have 5 minutes? Then we can have his presentation also. No? Okay.
Thank you, Arun sir. Very interactive and very informative.
I don't go to attend CMEs. क्यों? Because लोग बोलते कुछ है, करते कुछ है. So that is a very valid question. But lot of people are now practicing what is mentioned over there. In OPDs, most people are practicing when you have a pneumonia with amoxicillin or co-amoxiclav. We don't use amoxicillin-cloxacillin combination because that is an irrational combination. An ampicillin-cloxacillin combination is acceptable, but not amoxi and clox. Okay. And I'll just add one more point over here, a simple take-home message. Please, please, please don't use ferropenem in your practice. Use ferropenem very sparingly if you really find it is going to be useful. Because that is one antibiotic we may lose very soon if we don't stop using it irrationally.
Thank you, sir, for the most informative session.